Welcome everyone to our designated registered nurse prescribing Metro webinar this evening. Before we begin, I would just like to acknowledge and pay respect to the Whadjuk Noongar people upon whose land we are meeting on today. I honour their elders past and present and recognise the continuing connection of Aboriginal people to their lands, waters and culture. I also recognise the diversity and strength of Aboriginal peoples and the significant importance of self-determination and cultural knowledge in supporting the positive health and well-being of the whole community. Just a little disclaimer as well, the webinar this evening will be recorded. So we do have cameras and mics switched off for the time being, but we will be doing questions and answers at the end. So if you do have any questions, please feel free to pop them in the chat because we will have time to go through those and answer any questions right at the end. I'm joined today by Lisa Ville, who is the Acting Chief Nursing and Midwifery Officer at Department of Health, as well as Jill Law, who is the Acting Principal Nursing Advisor, also from the Department of Health. So welcome to you both. And without further ado, I will pass over to you, Jill.
Thank you very much.
Hi everyone, welcome to our webinar this evening and thank you for joining us. Jill and I would also like to acknowledge that we're meeting today on the lands of the Whadjuk people of the Noongar Nation, and we pay our respects to elders past, present and emerging, and we also acknowledge that some of you may be dialing in from other lands, and also acknowledge and recognise any Aboriginal people that may be joining us on the webinar today. So thank you everyone and welcome. And Jill is the wealth of all knowledge around designated registered nurse prescribing. So I'm sure you'll find the webinar really interesting, and please, if you've got any questions along the way, just pop them in the chat and we'll do our best to answer them at the end of the session.
Thank you, Lisa. So what is designated registered nurse prescribing? Well, designated RN prescribing, as we like to call it, because it's simpler to say, came into being in September last year, 2025, when the registration standard endorsement for scheduled medicines designated registered nurse prescriber was endorsed and approved by the Nursing and Midwifery Board of Australia. This came about after extensive public consultation that took over 10 years to get the standard into place. With lots of collaboration with the medical practitioners along the way and other health practitioners. And the standard allows suitably qualified registered nurses to obtain, possess, prescribe, supply and or use Schedule 2, 3, 4 and 8 medicines in partnership with an authorised health practitioner under a prescribing agreement. Now, these are the very important parts that you'll hear me say multiple times tonight, is that it's a partnership agreement with an authorised health practitioner. The authorised health practitioner must be an autonomous prescriber. We think that most often this is going to be a medical practitioner or a nurse practitioner, but may also be an endorsed midwife, a podiatrist, an optometrist, anyone else who can autonomously prescribe. So the designated RN prescriber, you can see here in this diagram, is surrounded by layers of governance and safety to ensure that this is a safe prescribing model. You'll have your local procedures and policies in place, followed by the NMBA endorsement and the regulation from the regulator for your policies and standards, as well as national and state territory legislation and regulations. And for us, that's mainly the Medicines and Poisons Act, the Medicines and Poisons Regulation, as well as the changes that needed for Services Australia to enable PBS prescribing. So the benefits of designated RN prescribing. Well, many patients currently need to make additional appointments just to obtain or renew their prescriptions, even when their care needs are well understood. Designated RN prescribing can streamline this by enabling appropriate prescribing within a nurse-led environment. This reduces duplication, improves efficiency, and allows other areas of the health system to focus on patients with more complex needs. And there's also improved quality and equity of care. So at its core, designated RN prescribing improves patient outcomes by enabling nurses to work to their full scope of practice and provide timely access to medicines within established frameworks. This is particularly important for people living in rural, remote, and underserved communities where access to prescriber can be a significant barrier. By reducing treatment delays, more equitable health outcomes can be supported regardless of where the person lives. It also improves access to affordable and quality healthcare. With PBS medicines closer to home, the patients can access PBS subsidised medicines through a designated RN prescriber closer to where they live, rather than travelling long distances to see another prescriber. This has particular relevance in areas experiencing medical workforce shortages. For many patients, accessing healthcare can involve significant travel, time away from work, and associated expenses. By allowing designated RN prescribers to prescribe within their scope of practice, this reduces the financial burden and supports more timely access to treatment. And it also reduces preventable hospitalizations, because we know that delayed access to medicine or interruptions to treatment can result in deterioration in health and potentially avoidable hospital presentations. So timely prescribing and continuity of care can help patients better manage chronic conditions and reduce the risk of escalation. It also supports multidisciplinary working and care coordination, and it's important to note that the designated RN prescriber does not replace other health professions. They strengthen the multidisciplinary care team by allowing nurses to contribute more effectively within collaborative healthcare teams, while maintaining clear referral pathways and communication with medical, pharmacy, and allied health colleagues. And this can improve continuity of care and create a more streamlined experience for patients. Ultimately, aligning a designated RN prescriber aligns Australia with other international healthcare systems where nurse prescribing is already well established and has been proven to be a safe method of prescribing. So implementing designated RN prescribing in Australia will ensure our healthcare system continues to evolve in line with contemporary international progress. So there are multiple program dependencies that we've had to work through to get to the stage that we are today. So along the top, you see the nurse's journey. So for a designated RN prescriber, your nurse needs to undertake a course of study from an approved university. The course has to be approved by the Australian Nursing and Midwifery Advisory Council and the Nursing and Midwifery Board of Australia. Once this course has been completed, your registered nurse can then apply for endorsement through the Nursing and Midwifery Board of Australia. When this is achieved, they can apply for the prescriber number through Services Australia and then prescribe confidently within their scope of practice. The prerequisites for the nurse's journey are what we call the dependencies. So when we started this journey over a year ago, there were more dependencies then than there are now. So there are now courses of education available for registered nurses to undertake. And I'll tell you where those courses are as we progress through this presentation. There are also clinical governance frameworks need to be in place within the organisations within which the registered nurses work. And this is to ensure safe prescribing, and includes the prescribing agreement, the mentorship agreement, and the authorised health practitioner. In relation to the regulation that needs to change for the PBS prescribing, amendments needed to be made to the prescribing for the pharmaceuticals benefits. Those bills were passed through the government just at the beginning of this month. And so registered nurses now will be able to apply for prescriber numbers to be able to access medications to prescribe on the PBS. They'll be able to apply for those prescriber numbers from the 1st of October this year. And the Pharmaceutical Benefits Advisory Council have also met and recently approved the first tranche of medications to be enabled on the PBS prescribing. To be able to prescribe Schedule 8 medications, changes need to be made to the real-time prescription monitoring systems within the states and territories of Australia. For WA, this is script checked WA, and the amendments will be in place before the end of this month to allow that prescribing. And locally, the changes needed to be made to our medicines and poisons regulations to enable registered nurses to prescribe. Consultation has taken place for the regulation amendments. These have been drafted and they're currently sitting with the legal teams and the drafters, and we hope that these will all be in place as well by the 1st of October. So national governance, the programme is governed nationally through layers of governance. So at the very bottom in the light blue, you'll see that there's an implementation oversight group. Sorry, underneath there's an implementation oversight group, which is comprised of the groups in the light blue. So that's the Australian Nursing and Midwifery Accreditation Council, the Nursing and Midwifery Board of Australia, the Chief Nursing and Midwifery Officers of each state and territory of Australia. Also on that group now is the Council of Deans. So this is our implementation oversight group. This group meets monthly to ensure that the progress of implementation is progressing throughout the countries. They're supported by a jurisdictional leads group, which is the principal nursing advisors across each state and territory. The Implementation Oversight Group report monthly to the Health Workforce Task Force, who then report all the amendments and changes up to the Chief Executive Forum and the Health Ministers meeting. Within Western Australia, we have our own governance structure as well. So we have a project team, which consists of myself as the project lead, Catherine Barrett as the project manager, and we've got Margaret Adijuma and Alison Wingrove, who are also helping in the project team. Our executive sponsor is Annie, the Chief Nursing and Midwifery Officer, and we report up through our Health Executive Committee to our Director General, the Implementation Oversight Group, and then back to the Health Workforce Task Force. So as you can see from this, it's a well-governed project. Each group of people within the project have key governance responsibilities. So I'll just start at the top of the Nursing and Midwifery Board of Australia. So they set our standards and competencies. They've set the standards, they've written the guidelines, there's fact sheets. The guidelines are going to be amended within the next 12 months. They're going to be reviewed. The standard at this stage will not be reviewed immediately, and the fact sheet is updated as required. They've also produced frequently asked questions and have a website available through the Commonwealth Department of Health and Ageing, and we'll be providing you with that link. So the NMBA approves the education pathways with the Australian Nursing and Midwifery Advisory Council, and they also provide the endorsements. So employing organisations, their responsibilities will be the key clinical governance framework and oversight of this. This will ensure that the RM prescriber is prescribing with competence and within their scope of practice. They have to look at policies and safety systems within the organisations, which may need adjusted in line with the standard and in line with the new changes to the regulations. They also have oversight of ensuring that all designated registered nurse prescribers are prescribing within a prescribing agreement with an authorised health practitioner. So the authorised health practitioner has clinical oversight of the designated RM prescriber. They can consult with them and support them through their prescribing decisions, and they participate in any audits that are required with the organisation and also with the NMBA. They're working in partnership with the designated RM prescriber. Ultimately, it's the designated RM prescriber who has that individual accountability and responsibility for all prescribing decisions that they make. They must prescribe within their scope of practice and context of work and maintain their competence in that. And this requires an extra 10 hours of CPD as per their endorsement. And this is in line with endorsed midwives and nurse practitioners who also have to undertake an extra 10 hours of CPD to maintain their prescribing competency. And the designated RM prescriber must work within the legislation, regulation and policy requirements of their organisation. So for those who are interested in becoming a designated RN prescriber, what is your pathway? So you have to hold general registration with the Nursing and Midwifery Board of Australia that has no conditions on it. You need to have completed 3 years of full-time clinical experience, which is 5,000 hours, within the past 6 years. You then need to complete an NMBA-approved units of study. These are at an Australian Qualification Framework Level 8. So it can be a full graduate certificate. There's a graduate diploma available as well, or it may be that you do just the equivalent units. So one university, which is the University of Melbourne, offers just micro-credentialed units, and those 2 units that you would do would meet the requirements for the NMBA approval units of study. Once the qualification has been obtained, you apply for endorsement by the NMBA. This gives you your endorsement for scheduled medicines as a designated registered nurse prescriber. Then, as I mentioned, you apply for a prescriber number with Services Australia and apply for real-time prescription monitoring if you're to be prescribing Schedule 8 medicines. At all times, once you've gained your endorsement, you need to ensure compliance with NMBA standards and guidelines. That's not just the standard for the designated RN prescribing, that's all the practicing frameworks within the NMBA, which includes your code of conduct, your code of ethics, and you also must work under the quality use of medicines prescription guidelines. Once everything is in place, you then can apply to your organisation through approval with a clinical governance framework and work with an authorised health prescriber under an active prescribing agreement, and also complete a 6-month period of clinical mentorship, which we can discuss more shortly. This prescribing matrix is just to show you the differences between the prescribing of an RN, the designated RN prescriber, and the nurse practitioner. It's extremely important that this is not conflated along the way, especially between the requirements of the designated RN prescriber and the nurse prescriber. So a registered nurse is qualified to an AQF level 7, which is a bachelor's degree, or a level 9 master's degree if they've done a direct entry master's course. They don't hold an endorsement, but they can administer medications that are prescribed by authorised health practitioners, and they can supply medications under approval of a structured authorisation and supply arrangements, which is a SASA. But they have no independent prescribing authority, and it's limited to those requirements and restrictions when they approve SASAs. Your designated RN prescriber, as we went over, have qualified to an AQF level 8 graduate certificate or diploma, with the 5,000 hours of post-initial registration experience within the last 6 years. They will hold the endorsement of designated registered nurse prescriber, and they can access and prescribe Schedule 2, 3, 4, and 8 medicines for a limited range of conditions within their scope of practice. And they must prescribe in the partnership with their authorised health practitioner and under the formal prescribing agreement. And again, this is not an independent route of prescribing, it's a partnership agreement. Your nurse practitioners are qualified to a level 9, have a master's degree in nurse practitioner. They have to do 5,000 hours at an advanced practice level. So that's the difference between your designated RN prescriber, which is your 5,000 hours after initial registration, as opposed to an advanced practice hours for nurse practitioner. Your nurse practitioner also holds an endorsement, and they can prescribe autonomously Schedules 2, 3, 4, and 8 medications within their defined scope of practice. Nurse practitioners can also diagnose, which is another difference between them and the designated RN prescriber. And they have full independent prescribing rights. So how are we progressing with our implementation in WA? Well, currently we're actively seeking early adopters, so sites who may have their clinical governance framework in place or are very close to it. We're asking you to come on board. We're implementing a designated RN prescriber project control group to work with our early adopters to help you ensure that your models of care are in place and you've got designated RN prescribers ready to prescribe. We have a WA designated RN prescriber advisory committee, which meets monthly. This committee consists of the directors of nursing of all the WA health service providers. There's also representation from WAFA, from APNA, from the Australian College of Nurse Practitioners. We have somebody from Edith Cowan University as our education provider, as well as private providers. We've got medical representation, pharmacy representation, Aboriginal health representation. And most importantly, we have a consumer on that group as well. We have completed our communication and stakeholder engagement plan. We have a dedicated shared email address, which is there for you. And we would encourage any questions that you have. If you don't want to ask them tonight, then please do submit them through this email inbox. There's a few of us have access to that, and we will definitely get back to you. We also have a dedicated web page. The address is there, and I think that's been put in the chat for you. And I'd encourage you to have a look there. So any updates are put there. Any implementation toolkit, which we're developing, any resources will be placed on there as well, that they'll be free for everybody to have a look at. We also regularly communicate through social media, through LinkedIn, the Department of Health webpage, through HealthPoint for Department of Health. Emails get circulated through our advisory group, and we're doing media forums like this. So I did mention the WA Medicines and Poisons Regulations 2016. They're currently being updated with the drafters and will hopefully be ready for October the 1st. We have developed the Prescribing Agreement and the Clinical Mentorship Agreement. These are compulsory documents that sit within your clinical governance framework. These have been developed at a national level. They have been consulted on, and we have done national consultation, and these have been revised and have been approved through the Implementation Oversight Group and approved at each jurisdiction by Director Generals or equivalent. So the WA one is currently sitting within our communication team to ensure it meets with the WA style guide, and then it will be published on our website. And I would hope that that'll be within the next week or two. And I would encourage you to have a look there at those documents. I'm going to go through them in more detail just in the next few slides. To support the Prescribing Agreement and the Clinical Mentorship Agreement, which are extremely high-level documents, we have developed a prescribing guidelines and mentorship framework. These have currently been consulted on. They've been through 2 rounds of consultation. They've been adjusted to reflect the feedback. They have been approved by the Advisory Committee and are just currently waiting to be approved by our Nursing and Midwifery Leadership Council. And again, once fully endorsed, they'll be available on our websites for you. We have developed a policy, the WA Health Authorisation Monitoring and Assurance Policy, and that's currently sitting with our policy writers. And we also have an implementation toolkit. So on top of the documents I've already described, within the toolkit, we'll have some vignettes. So examples of where designated RN prescribing can work, and scenarios to show you where that can be enabled. And to sit alongside these, we'll do example prescribing agreements so you can see how those work together. So the prescribing agreement is a formal written agreement. This includes, I'm just going to read this slide for you, so I'm not missing anything. It includes the roles and responsibilities of the designated RN prescriber and the authorised health practitioner. It includes the scope of practice of the designated RN prescriber, and this will be individual to each designated RN prescriber and will be dependent on their context of work, their area of work, and their scope of practice. It will include the medicines, so the medicines themselves and the class of medications that the designated RN prescriber is authorised to prescribe in partnership with their authorised health practitioner. It'll detail the processes for consultation and referral should the designated RN prescriber feel that the prescribing is out with their scope of practice. Yes, I can clarify who an authorised health practitioner is for you. So as I mentioned at the start, we see that this will predominantly be medical practitioner or a nurse practitioner. It has to be somebody who can autonomously prescribe. And the designated RN prescriber can only prescribe within the scope of practice of their authorised health practitioner. So as I mentioned, your optometrist, podiatrist and endorsed midwives are also autonomous prescriber. However, they all have quite narrow and restricted scopes of practice. So for a designated RN prescriber working with them, their scope of prescribing would also be narrow because it can't be out with their scope of practice of the authorised health practitioner. So back to the prescribing agreement. So it also details the individual arrangements that need to be in place when there's multiple authorised health practitioners. So we understand that in some contexts, especially in rural, remote, and perhaps aged care facilities, there may not always be one single authorised health practitioner available at all times to be in partnership with the designated RN prescriber. So there is that arrangement in place that more than one authorised health practitioner can be involved. The prescribing agreement also details the process for resolving or escalating differences of opinions and the process for monitoring and audit of designated RN prescribing. So as this is a national standard by the Nursing and Midwifery Board of Australia, as part of the endorsement, the designated RN prescriber may at any time be asked to show their prescribing agreements that they've had in place. So it is a requirement. These are kept by the designated RN prescriber, the authorised health practitioner, and the employer. So each prescribing agreement is dated with a plan for review. And these need to be reviewed at least every 12 months. They also need to be reviewed and amended and a new prescribing agreement entered into should the designated RN prescriber change their role, change their context of work, or change their scope of practice. So this is just our, I've got a few slides now that shows you our prescribing agreement. As you'll see from this, it really is very high level, and the prescribing guidelines that will be published as well will talk you through this in more detail. So it looks for the demographic information of the designated RN prescriber, their name, title, endorsement details, registration number, employer number, if relevant, who their authorised health practitioner or practitioners are, and that includes their name, title, role, and registration number. And the date of their prescribing agreement review, and the name and address of their organisation and the clinical service that they work within. For the areas where it's relevant, the clinical service director's name also needs to be included, and the line manager. Now, we recognise that this says the line manager is optional. We would be recommending that all line managers are actually included within the prescribing agreement, as they will have oversight of your designated RN prescribing and need to be aware of what their registered nurses within their areas of work are prescribing and partnership agreements that they have in place. It also includes the clinical mentorship agreement details. So your scope of practice, this asks for any postgraduate education and training that the designated registered nurse prescriber has undertaken. This will include their qualification to become a prescriber and also any other certificates that the designated RN prescriber has undertaken. So we have an example there of somebody who works in palliative care may have a graduate certificate in palliative care. And then we go on to list the scope of practice. So you outline your scope of practice within which you're working in the clinical service. List of documents there that we recommend are included within any prescribing agreement, just as reference points to look upon. This allows you to look at current best practice and working within your scope. Then it moves on to discuss the authorised medical conditions and indications for which prescribing is going to be enabled. Yes, I can answer these questions at the end. So the authorised medicines that the designated RN prescriber may commence, continue, and or cease to prescribe are listed here. Listed under medicines are listed under their therapeutic class, which may be easier than if there are multiple medications within one class or multiple drugs that the designated RN prescriber is going to be able to prescribe. And you can detail there whether they are able to prescribe new medications under the classes, whether they can continue therapy, or whether they can cease. And any exclusions can also be written in here. There's also a section specifically for Schedule 8 medications, and the conditions and indications when these can be prescribed and any exclusions and limitations. noting that you need to have at the bottom there that real-time prescription monitoring in place because it's a compulsory that WA script check is checked prior to prescribing any monitored medicines. And then just lists what needs to be done for any clinical escalation, clinical dispute resolution, any professional disputes that may occur. And then we go on to the monitoring, any safety and quality governance processes that are in place. When this here is to list any local policies and procedures in relation to prescribing that you have. And the last page of the agreement is just for your registered nurse and the authorised health prescriber to sign against each of these statements to ensure that they've read it and understood it and will comply with them. So the other mandatory document that needs to be completed as part of the clinical framework is your clinical mentorship agreement. This clinical mentorship agreement is for a 6-month period, and it supports the designated RN prescribers to develop their experience and confidence in prescribing. Now, although it says here this is for their 6 months of their prescribing practice, should a designated RN prescriber, again, change their context of work, their place of work, or their scope of practice, they'll need to enter a new clinical mentorship agreement for a further 6-month period. If at the end of any 6-month period there is considered either by the mentor or the mentee that it would be beneficial to continue the mentorship agreement for a further period of time, then that's absolutely acceptable. So the mentorship agreement outlines the framework for mentoring. It includes and defines expectations, boundaries, roles and responsibilities, and the communication methods. It requires the signatures and approvals from the designated RN prescriber, their authorised health practitioner, who is their mentor, and this can be a different authorised health practitioner to the one who is their prescribing partner. Again, your line manager must sign it, as well as clinical lead and professional reporting line. So this is the clinical mentorship agreement that we have endorsed within WA. As you can see, it is a very high-level document. Our clinical mentorship framework that we have also developed is a much more expanded document that will talk you through the principles of mentorship, and it uses an IGRO model as a recommendation that you use. Now, while this mentorship agreement that's signed the agreement here says that we would recommend that you meet at least monthly. The NMBA standard doesn't put any timeframes on how frequently a mentor and a mentee need to meet, but we would recommend this as monthly so that both the mentor and the mentee get the most out of the clinical mentorship agreement in their period of working together to consolidate and provide that support and confidence to prescribe. So programs and scholarships. There are currently 5 accredited programs of study in Australia. There are more who are currently waiting to be accredited, but the 5 currently are Edith Cowan University here in Perth, WA. Their first course opens next week. We have supported staff through there and encouraged local residents in WA to be enrolling into Edith Cowan University course. La Trobe also offer a course, as well as the University of Melbourne, Queensland University of Technology and the University of Tasmania. While there are differences amongst the courses, all of them will provide you with what's required to become endorsed. So we are aware that Edith Cowan is offering Commonwealth supported places. We're aware that the University of Melbourne is not, and while they offer the micro-credentialed units and you only need to complete 2, their units are $7,000 each, roughly, as opposed to Edith Cowan University, where the units are just less than $800. The University of Tasmania course is also a graduate diploma course, so that's a 2-year course, as opposed to ECU, which is the graduate certificate and can be completed in a year. And the Chief Nursing and Midwifery Office has entered into a collaboration with ECU to support 80 students over 4 semesters with full scholarships to obtain their qualification. We have closed our first round of scholarship applications. The next round will open September, October time. If anybody is thinking of doing the course, we would encourage you to apply for a scholarship. But we also note that scholarships are available from the Australian government that are administered by the Australian College of Nurse Practitioners, and they focus on primary care, nursing and midwifery. And again, they will offer full scholarships. And if anyone's within the aged care sector, then there's also an aged care nursing scholarship being administered by the Australian College of Nurse Practitioners. And anything with designated RN prescribing is also included here. And again, it's fully funded. So I would encourage you to seek all scholarship opportunities. This is just to show you what will be in our toolbox within our implementation kit that we're going to have. I've talked through the agreements, the guidelines and the framework are supported documents for the agreement. Our policy will be there, and we're also going to be develop guidelines to go alongside the policy. We will have our suite of vignettes along with frequently asked questions, and we're going to be developing a consumer fact sheet because this has come as a recommendation from our consumer who sits on the advisory group. So for individual health services and organisations, there is some work that needs to be done for implementing this new reform. The clinical governance framework is mandatory within the standard. It needs to include safety and quality, so ensuring that any incidents and adverse events can be reported and monitored, and that you're monitoring and reviewing all prescribing that's happening within the workforce by designated RN prescribers. You may have medication policies in place that need to be updated and amended in line with the new standard and the new regulations once they are endorsed and approved through the Parliament. And you also need to have monitoring and assurance in place that your designated RN prescriber is meeting the requirements of the standard, that they're being endorsed each year in line with the registration period, and that they're also completing those 10 extra hours of continued professional development. Your strategic considerations are to look at where is the service need. So where is there a gap within the service that you're providing that a designated RN prescriber can fill? And as I go back to the benefits I talked about at the beginning and bring those models of care with benefits to your community and value add to improve patient access and patient benefit to prescribed medicines. Change management is an important part of introducing any new reform. And we would highly encourage that there's a lot of communication so that people know that this is in place, what a designated RN prescriber is, what the arrangements you have in place, and any training activities for the designated RN prescriber or for the authorised health practitioner so that they also are aware of what their commitments and responsibilities are. And also look at any implementation support that you're able to provide for both the designated RN prescriber and the authorised health practitioner. So as with any service change reform, there are lots of risks. We identified lots of system risks when we started on this project. What were once very extreme high risks, a lot of them are now moderate risks because we're now a year in. And if we just look at there, we've got limitation of availability of insufficient access to required education courses. When the registration standard was first endorsed, there were no courses available. So we now have 5. It's not a lot, but it's definitely a start. And as I said, there are more courses waiting to be accredited. So there's always a risk that there's a lack of stakeholder engagement and participation. We would like to think that there's more people coming on board and learning about it, although we are aware that there are still gaps in that and that we need to have consistent communication and engagement across all areas where there may be registered nurses who are interested in undertaking this course and can fulfill the model of care and become a designated RN prescriber. There was a concern that there would be lack of engagement from medical practitioners, pharmacists and nurse practitioners. However, because the medical practitioners, pharmacists and nurse practitioners have been on the journey with us from the start, we're finding that that engagement is very positive. And we've had very little stakeholder resistance that we're aware of. I'm sure there is some, but there's not as much as we had initially anticipated. We do understand that there may be challenges with the engagement with the partnership model of prescribing and that mentorship agreement. So that will remain a risk, and it might be a risk, especially in communities and areas where there's not so many people around as in our large health service providers. So we know that this may be a risk within primary care areas. There was a risk that the Commonwealth and state legislative regulatory amendments would be delayed. Thankfully, as I said, the PBS legislation has passed through the House of Senate Representatives and is now law. And our current WA amendments will be in place shortly too. So one of the other questions we quite often get asked is in relation to indemnity insurance. So we are aware that any designated RN prescriber and authorised health practitioner who work within one of our health service providers or within the large private providers are covered within the insurance of the hospital. So we would encourage you to seek what insurances there are within any organisations, places that you work within, or what requirements are necessary if you need to have your own independent indemnity insurance to become a designated RN prescriber. Okay, I think that's the main risks. So in summary, their strong governance is essential for safe designated RN prescribing to work effectively and efficiently within the system and areas of work. There needs to be that clear authorisation, mentoring and policy frameworks, because these will underpin success of the reform. You need to look at your risk mitigation and quality insurance because these need to be embedded from the start. And the accountability of the organisation needs to be looked at to ensure that this can be a sustainable model of care with continuous improvement to provide those benefits to consumers. And our email address and website is just there again for you. So thank you. That is the end of our presentation.
Brilliant. Thank you, Jill, so much. This brings us to our Q&A section, and we have a couple of questions to get through. The first one being, is there an understanding that MBS item numbers will be made available to the nurse prescriber in a GP setting once they are registered?
Thank you. So currently there's no established MBS item numbers set for designated RN prescribers. We are aware of this. It is something that is recognised by the Implementation Oversight Group as well. On that group is Alison McMillan, the Commonwealth Chief Nursing and Midwifery Officer. So she is our conduit to actions that need to be done at a federal level. So this has been raised. The current focus, however, has been on obtaining PBS access to enable PBS prescribing, which has been enabled. So that in itself is a big win, and the MBS items will hopefully follow.
Lovely, thank you. Our second question is, I am already a qualified remote area nurse and have been practicing for many years in the primary healthcare settings in remote Aboriginal communities. I have all of my RAN qualifications as well as a master's degree. Will these qualifications be recognised in this new primary healthcare setting in Perth, as opposed to only being recognised at designated nursing posts in rural and Aboriginal communities remote?
All right, so thank you. This is a good question. Unfortunately, I'm unable to comment as to whether a new employer in Perth would recognise those existing qualifications. Some of the expanded practice authorities that apply in designated remote nursing posts may not automatically transfer into metropolitan areas, and this would depend on your local governance arrangements, your employer requirements, and any legislative and endorsement frameworks. In relation to designated RN prescribing, though, your experience gained as a remote area nurse is relevant to the clinical hours that would be required for that endorsement. But to become a designated RN prescriber, you do have to complete one of those ANMAC and NMBA approved courses that leads to a qualification in designated RN prescribing. So I think a qualification as a remote health nurse, if you've done a qualification there, would need to be, it may be, you've obtained the qualification, but you will have to complete the required designated RN prescribing qualifications or units of.
Lovely, thank you. My third question is,
sorry, can I just say, because Nicole just put up that question in relation to this, will RPL, that would depend on the university that you go to. You would have to submit all your documentation and transcripts from your qualifications that you have achieved to the university you want to sit your qualification at, and they would look at any RPL that you may be entitled to there.
Lovely, thank you. And thanks, Nicole, for that as well. Would or could this be used in a corrections setting? So I assume they're referring to the program.
Absolutely. So designated RN prescribing model is intended for any setting, and it's designed so that implementation can occur wherever the necessary governance, prescribing arrangement, and legislative requirements are in place. So designated RN prescribing could prescribe within a correctional health service. If the correctional health service supports the model, there's a model of care in place for prescribing, that appropriate clinical governance arrangements are established, that there's a prescribing agreement in place with an authorised health practitioner, that the medicines and clinical conditions covered are clearly defined, and that the arrangement complies with relevant jurisdictions, legislation, and correctional health policies.
Great, thank you for that. Can you please clarify who is an authorised health practitioner?
So I think I did discuss this. So it's any autonomous prescriber. And again, as I said, and I'll just reiterate that the designated RN prescriber can only prescribe within the scope of that autonomous prescriber as well. They can't prescribe out with their scope.
Thank you for that clarification. Will the authorised health practitioner need to be on site when the RN prescriber prescribes?
They don't have to be on site when the RN prescriber prescribes. As long as the designated RN prescriber is aware that if anything happens, if there's a change in medical condition of their patient when their authorised health practitioner is not there, that they're able to contact them to discuss any changes that they feel is out with their scope of practice. So it's just to remember and work within that scope of practice, within your prescribing agreement, that you're not prescribing any medications out with that, and also to know your processes in place if there's any escalation of care that is required, because having the prescribing agreement doesn't take away from any other policies and procedures that are already in place when you've got a deteriorating patient.
Perfect, thank you. And my last question is a postgrad qualification necessary, or is experience within a clinical area sufficient?
No, so you do need to have, when you get the slide deck, if you go back to the requirements, what's needed to become a designated RN prescriber, you need to have that postgraduate qualification. So you don't already need to have another postgraduate qualification. This can be your first one. To obtain your endorsement, but to obtain the endorsement, you need to have the postgraduate qualification or the units of, as I say, there are just 2 units sometimes that are necessary. And if you just do those 2 units that satisfy the requirements by the NMBA, then that's all that's sufficient. However, we would recommend, purely from a WA health perspective, that you complete the full certificate or diploma, because that then could lead to a qualification allowance, and within under which awards that you're working under, that may also be the case. If you've only done the designated units, you wouldn't be eligible for a full qualification allowance.
Thank you. That is all the questions that we have this evening. If there are any questions that you feel like you want to ask our speakers today, feel free to get in touch with us after the webinar, and we'll be able to take those conversations offline. So upcoming events, tomorrow we have our designated registered nurse prescribing update and overview for country. So if you or anyone in your networks would like to join us, I have just popped the link to the registration page in the chat. That is tomorrow evening at the same time, 6 p.m. And I've also added a link to our feedback survey. So if you could just take a couple minutes just to fill out our feedback survey, it really helps to give us some feedback in terms of how you found the webinar tonight, as well as any future topics you want to see from us here at WAFA. So I will leave that up for a couple minutes after the webinar as well. But on behalf of myself and Lisa, Jill, Nicole, I want to thank you for joining us this evening, and I wish you a lovely evening.